Hello, good afternoon. I'm Alex Muggy, the Chief Health Informatics Officer and Director of the Health Informatics and Interoperability Group at CMS. Welcome to the Connecting Patients and Care Providers Across the Healthcare Enterprise. In this panel, we want to talk about how technology can connect patients, providers, payers, and others across the healthcare enterprise to reduce burden and achieve better outcomes for patients. Technology is an incredible resource, but if it's not implemented appropriately, it can actually contribute to burden. And that is certainly something that we want to avoid. So today, we want to get into the weeds of how this innovative stuff can best support our healthcare ecosystem and where we see opportunities to use technology to eliminate unnecessary burden. We are going to bring you that perspective from just about every possible angle in this panel. So I'm going to go ahead and introduce our panelists. Joining me today, we have Dr. David Graham. Dr. Graham is the Chief Medical Information Officer at LifeBridge Health. He is board certified in family medicine and clinical informatics and is an experienced clinician and informaticist with more than 25 years of experience in health IT and medical education. Dr. Graham brings us the perspective of a clinician informaticist in a major health system with deep experience in what it means to implement new technology and in a health system, and what impact that can have on the providers and on patient care. So thank you for joining us, Dr. Graham.
Thank you.
Dr. Ron Klein is a board-certified pediatric hematologist, oncologist, and the Chief Medical Officer of the Quality Measurement and Value-Based Incentives Group in the Center for Clinical Standards and Quality at CMS. QIMVIG, as the Quality Measurement Group is referred to, is responsible for development, evaluation, implementation, and support for quality measurement programs across the entire federally funded healthcare continuum. He also works on weekends as a pediatric emergency department physician at Ascension St. Agnes Hospital in Baltimore. Dr. Klein brings us government and regulatory and quality reporting perspective with a clinical twist. Thank you for joining us, Dr. Klein.
Good afternoon.
And Heidi Chris is the Director of Medical Policy and Medical Management at Regions Health Plans, where she leads strategy and execution of medical policy and utilization management and transformation decisions. Heidi completed her Master of Public Health with a focus in epidemiology and healthcare administration and is a registered dietitian. She has over 18 years of experience in evidence-informed health policy and management leadership positions across health plans and health entities. Heidi serves as the chair and business lead for Prior Authorization Transformation Program, directing several initiatives for electronic and auto prior authorization workflows, EHR interoperability, automation using artificial intelligence, and selective applications of prior authorization. Ms. Chris has a wealth of information and incredible experience and has significant insights on burden reduction from the payer perspective. So thank you so much for rounding us out with that experience, Ms. Chris. And finally, Dr. Viet Nguyen. Dr. Nguyen is the Chief Standards Implementation Officer for HL7 and serves as technological director of the HL7 Da Vinci Project. He is an internist, pediatrician, clinical informaticist, and consultant to government and commercial organizations in developing interoperable workflows and technologies. He has 2 decades of experience in health IT focused on interoperability standards and product development, and he is the former CMIO for Lockheed Martin and Leidos Corporation. Dr. Nguyen brings us the perspective of a technologist in the depths of standardized informatics who is also a pediatrician, one I have personally gone to for my own children's medical advice. So thank you, Dr. Nguyen, for being here today. Together, these folks can tell us the great, the bad, and the ugly of technology updates to address burden. So you can read more about all of these incredible people and their full bios on the website. But for now, what you need to know is that this is the panel for addressing the future of healthcare burden reduction, and we're going to look at it from every angle possible. So let's go ahead and get started. The first question I'd like to address to Dr. Nguyen, to help us level set, because not everyone here is going to have the same level of understanding when it comes to technology standards and interoperability. What are the standards in healthcare interoperability, and how does this impact burden, and what is this HL7 thing?
Sure, great. I'm happy to join. Thank you for the opportunity. To level set, interoperability and standards is really an approach to a common understanding of terms, protocols, specifications, and now even more so workflow, where we want to standardize it in order to improve data quality, data exchange, and all the secondary uses of data. And it really, with HL7, we have been focused on the clinical record and medical records, medications, radiology, but we're also part of a broader community of standards developers, including X12 and CPDP, that look at administrative data or pharmacy data. So we're one of several. And I'd like to say that interoperability combines all those so that you can answer the what do I need to share? How do I share it in the structured form? How do I connect with the partners that I need to share with? So it's important because data is not our own anymore. It's being used for as quality reporting and other aspects. And so HL7's role is that we are an ANSI accredited standards development organization. We have a foot stamp that's really international with our affiliate partners. And we have a large number of organizations as well as individuals who are our members. And we like to say that interoperability and standards is really a journey. It's not something that's done the first time. And so I think that's an important thing to note. And just to add on a little bit, I listened to the sessions earlier today. I thought they were phenomenal. And the panels really described a number of problem areas that we have in exchanging data and delivering care. And so I just wanted to briefly note some of the things that HL7 has done to try to address that, but I'll leave the burden reduction for Heidi. But really, it was mentioned quality was a huge part of the first panel, and the challenges providers have because they're getting quality measures from different organizations. They're having to apply them to their systems. They're having to do the reporting. It's often very abstract. HL7 over the last, I'll say about 6 or 7 years, has actually developed an approach to standardize the representation of the quality measures in a standard form, recognizing that we could retrieve data from the EHR with standard data based on the ONC's certification requirement. And we've tested them from the get the measure, grab the data, and report it to a measure authority in a seamless, nearly human not needed way, except to check. And those are really good for very good structured data. And we recognize that not all our data is structured. But then HL7 is also starting to work with some of the measure authorities like CMS to start to look upstream. How do we start to create measures that can know the questions that are asked? Our answers may be already available in structured data in the EHR via FHIR and the ONC data standards. So I think we'd like to get to that point where it's really seamless end to end, and I like to say standards from the start and at the end too, I would say. So I think there's lots of promise with the measures community as we're trying to transition, and we're well on our way with the ONC requirements. Another briefly, transitions of care. HL7 it has a work group working on the post-acute care transition and trying to standardize what we know to be the transition of care, the conditions, interventions, and goals. And then with that last group, health equity is a growing activity in HL7, and which we've actually started to establish. Last week at NCQA, I got to speak. There are already a large number of standardized data based on ONC certifications to support transition care. It's a foundation. It's not complete, but we do talk about race, ethnicity, geolocation, and along with the social determinants of health, those add on to work that we're already doing. We have some guides around social determinants. So we like to think interoperability is really a multidisciplinary team activity. A lot of it is change management. I think of interoperability as a vertical from the executives all the way down to the developers, not down, but including the developers. And so the workflow folks and the business owners are important aspects of really implementing interoperability well. And lastly, I reinforce this, and Alex has heard me say this before, but we really think, and I very much think, that interoperability should become a strategic initiative for organizations, because we're letting go of the I own the data. So now what can you do with that data to improve patient care, to make things more efficient, to provide more services to members? So it shouldn't just be a compliance activity. So thank you. I know that was a little long, but thanks for the opportunity.
No, that's perfect. So we talk about, I know there are a lot of different definitions of interoperability out there. And when we talk about it in the healthcare context and the work that we do at CMS, we often refer to it as the ability of two systems to exchange health information in a way that the person on the receiving end can make meaningful use of that information. So in that way, that the fact that it's standardized means that I'm not receiving a bunch of like gobbledygook at the end, but I'm receiving real information that I can act upon. And you can see how that would contribute to burden reduction. So would you say that that's an accurate-ish definition for sort of each of the use cases that you just talked about?
Yes, very much so. It's that notion now that we're getting in more into workflow interoperability, and Heidi will talk a little bit about like how we have to collect data. It's not staying in our own systems. It's all those numbers of secondary users who need that data for quality, need that data for clinical decision support, patient care, reporting, prior auth. So we want to go beyond just exchanging data to how does that work, the data support a particular workflow.
Absolutely. Yes. Thank you very much. So, so since we've given a nod to Heidi, let's go to you next. As part of your work at Regence Health Plans, you've been part of a team that has seen remarkable success automating the prior authorization process using the very standards that Dr. Nguyen was just mentioning. We all know prior authorization is part of the healthcare system, and it's here to stay, and it has a critical role. But we also know that it can be burdensome for just about everyone involved. Can you talk about your work automating the prior authorization process and how it came about and why you think it has been so successful?
Yeah, thanks, Alex. Thanks for having me. Really excited to talk about our work in this space. For us as a health plan, I think there's a common misconception that the health plan loves prior authorization, that we want to do it. Nobody loves it, right? It is administratively burdensome, and it's something that we need to solve for today. We need to stop saying that it's too complex, we can't do it. We can absolutely do it, and that's what we're trying to demonstrate. So in 2017, our CEO at the time said that we need to get to a place where our members on the health plan don't experience the process. And that was really ultimately what led us on our vision since that time. And at the end of the day, we also need to bring in our provider partners, right? It needs to be transparent, and we need to keep them in their workflow, which is the EHR. So at that time, we recommended that we needed to be interoperable as a health plan with our provider partners. And we need to form a partnership, right? We have to break down silos to make this happen. So when we launched initially, we did use a portal, which is not ideal, but it allows us to build the foundation and the tools and the infrastructure that then to lift and shift. So we went live with our payer to provider FHIR-based prior authorization workflow in October of 2022. So we have real prior auth transactions coming from the EMR into the health plan directly. With that, we can start to eliminate some of the human input that's needed, right? That burden that we've talked about. And then we can start to automate things on the health plan side. So there's a lot of automation happening to make it faster. And I think this really serves as a foundation to get to where we want to get to tomorrow, which is that ultimate vision of allowing a provider and a member to have a conversation about their healthcare decisions that they need to make at that point in time.
Yes, I love that concept of not experiencing the prior authorization process, and your team has done excellent work in helping to achieve that. So you mentioned that you started with a portal, and that's not ideal. And I think we too have heard from providers that if every health plan has their own portal, that's a whole lot of portals and a whole lot of passwords that they have to manage and remember, and then that can be part of the challenge. So so what would you recommend to anyone who's considering a project like this? If it's not starting with a portal, what is a good starting point, and what would you recommend to someone who's just getting started?
Yeah, so we're calling it portalitis. We can't continue to make providers go to every portal for every time we need to exchange clinical data per health plan. It's not fair, and it's just completely unacceptable. And so I think moving this direction allows us to use the same data standard and get away from all these portals, keep the providers in their workflow. I think you guys called it out earlier, right? First and foremost, you have to have organizational support. It has to come top down. That is where we started. That was our vision. Our CEO pressed it within our organization. And prior authorization is not a simple process. I bet we have at least 8 to 10 teams within our organization that touch it. So we have to have organizational alignment. I think the same is true on the provider side. they have to come as a strong collaborator in this, right? And provide feedback. We needed to find a provider partner that was innovative, that we knew would fail with us a few times, right? This is all new, so we're not going to get it right the first time. And that was really for us one of the most important things. So we had a framework that we were using to evaluate which provider is best to launch this from. And then once you launch that, from there you've got it nailed down, and then you bring providers to the table. The other thing for me that was really important was showing providers that they got value out of it immediately. And by that, I had to develop a good workflow that did what it was supposed to do. It was transparent. Payers have to drive an adequate PA check. That is the benefit, really largely with this, is you cannot give them an unknown response. And so we spent a lot of time developing a really good PA check to give them a solid answer. And with that, it's baby steps, right? As an organization, when you're innovating, start somewhere. You can't just say it's too big. You start somewhere small and then continue to build upon it. So we started with that PA check. We started to build out our criteria sets electronically so we could show them in the EMR to the providers. They can see transparently what is required for payment by that health plan for that service. And then we just continued to build from there. Now we have a dashboard. We're returning determination letters back to the providers and their EMR as well. So we're just continuing to build and make it better and automate more. And the last thing I'll just call out that I think is really important is I get a lot of questions. Is this technology or is this business? It's both. You both have to come to the table and collaborate together. And with our organization, and even with the providers organization on our calls when we were doing this work, both of us had business and tech teams there, and we were very transparent with each other to, again, break down those silos, build trust, and develop something truly impactful for our providers.
That really goes back to what Dr. Nguyen was saying, is that, it's not, interoperability is not a compliance effort. It really has to be a strategic objective. I am going to put you on the spot, and this wasn't in the questions that I sent you, but I'm going to ask you, and then you can say, no, you can't share. But do you have any statistics or data that you can tell us about your pilot? Like, for example, with providers who are using the API for prior authorization, sort of what some of the benefits are that you're seeing?
Yeah, so first and foremost, what I would say is, as I mentioned, the prior auth check is the most volume coming in that workflow today. That is the most important thing. And we can actually automate some of those form fields so they can get just a quick answer, whether it requires prior auth or not. And when it doesn't, they can have that conversation with the patient right then and there or schedule the surgery. So I think that's first and foremost one of the most exciting things, and it's in the EMR. Secondarily, as I talked about, we built out our policy criteria sets electronically. We're actually codifying clinical data to automatically come in as part of that policy, which allows us to, again, to start to automate and then build rules engines off of some of that work. What that does is it allows us to give auto approvals on policies that normally a human would look at it, which is what takes a lot of the burden and the time to get the determination back to the provider. So with that automation, right now we have over 4,000 transactions that have come through our workflow today with the providers that we're using. And right now we are giving them an immediate response 89% of the time that they have inquired with this workflow, which I think is extremely exciting for us, for them, but most importantly for our members getting fast decisions so that they can move forward with their treatment pathway.
That is an incredible amount. I mean, think of all the time that someone would have previously spent waiting for just a feedback on whether they even need prior authorization, and you're solving that right there in the clinician's office. So that is really incredible. I am going to take an opportunity then to mention, for those who don't follow all of the CMS regulations that come out, that the Office of Burden Reduction and Health Informatics last December put out a proposed rule that was proposing to require that almost all the health plans that CMS regulates would also build a prior authorization similar to what Heidi was just describing. This is an application programming interface, or API-based prior authorization process that allows for electronic prior authorization, so that a provider can query whether a prior authorization is even required, determine what documentation is needed to submit the prior authorization, then actually go ahead and submit that prior authorization if it is required, and receive a determination from the payer. So it's kind of an incredible process, and we thought it was incredible enough to propose that would be required for all payers to build the API. And we included also a measure for providers to encourage them to use the API as well. So in that way, establishing some of those partnerships and making sure that we're bringing both the payer and provider community to the table to streamline what has historically been a pretty burdensome process of prior authorization. So more to come on that. The rule was proposed, but the comment period is closed and it hasn't been finalized yet. But maybe at the next conference. So thank you for sharing that, Heidi. That's super interesting information in practice. So moving to Dr. Klein. So when we talk about interoperability, in addition to prior authorization, one of the other major use cases that we talk about is the exchange of quality measure data. But much like prior authorization, quality measures are a critical part of the healthcare system, but we also know that they can be associated with a certain level of burden, a certain level of administrative burden to collect and submit the information. And often we hear from providers that they're required to report to multiple entities, all of whom have different data points and reporting requirements. So from the CMS perspective and the work that we are doing, how will the data standardization that we've been talking about help to transition to digital quality measures? And what activities is CMS focused on for standardizing and streamlining the data submission process to reduce burden?
Good afternoon, everyone. Good morning to those on the West Coast. So I'm going to start by citing a paper that I think Dr. Shannon cited in his presentation, which was from Johns Hopkins and talked about the $6 million spent on quality measurement. Fascinating paper. I think it was June of JAMA. And I guess it's sort of like the parable of three blind men describing the elephant. Because Dr. Shannon talked about $6 million spent on quality measurement, and Johns Hopkins is a wonderful medical center. I work there twice a month in pediatric oncology, and it has a $2.5 billion annual operating budget. So that $6 million they spend on quality measurement is roughly 0.25% of their operating costs. So again, $6 million to $6 million, it's also 1% of their annual operating budget. I think it's important to put that in perspective. The other interesting part of that paper was a comparison of the costs of the burden associated with different quality measures. And depending on what the comparison was to, the electronic measures cost anywhere from 1/15th to 1/20th of the cost of other electronic measures. So to your point, without sounding like Nirvana here, but the way we get to decreased administrative burden is to get as rapidly as possible to digital quality measures, because that can automate the process, it can automate extraction, it can automate export, and it allows things to get directly, basically letting the clinician take good care of their patients, which I always emphasize is not a burden. If it is, you need a different profession, and just letting the data systems collect the quality measurement. Currently, 80% of measures that CMS has are digitally sourced, so we're 80% of the way there. 24% of our MIPS measures are currently ECQMs, so we're working on getting there. I think the other point, we'll talk later about USCDI and other things as well. But I think the other important point is that sometimes government gets blamed for things that aren't its fault. So my boss, Michelle Schreiber, who's our group director, and was formerly the chief quality officer for Ascension in Michigan. I'm sorry, the Henry Ford Health System in Michigan. Always talks about the fact that she had an Excel spreadsheet with 650 different quality measures that she had to track. But half of those or less were from the government. The other half were from commercial insurers who would take a quality measure that was pretty much like a CMS quality measure and alter it slightly, but alter it just enough that it had to be reported differently and collected differently. So part of the way we get to decrease administrative burden is to align our measures, and that's part of this is on us within CMS, the federal government, to align quality measures within our own house, because unfortunately some of our measures are a little bit different, and we're working on trying to synchronize them, align them. But once we get our own house in order, the next step is really to go out to the commercial world and say, look, we have a measure that's almost like yours for hypertension or diabetes, or hospital-acquired infections. Change yours a little bit so we can eliminate some quality measures. So I think it's getting to a digital world, and it's getting to alignment across the healthcare continuum.
I think that's really great to hear that, first of all, that we're working, not just within our own shop, but looking externally to help to align measures. Because again, I think you're right. I think that's where a lot of the burden comes from, is just having the same measures, but just the slightest changes then changes all of the standardization that goes into it and changes the ability for technology to really support that, right? Because technology can focus on one measure, but if you keep tweaking it, then it actually becomes multiple separate and distinct measures.
Well, a real simple example, right, for folks out there is how we define good diabetes control. And there are quality measures out there for hemoglobin A1C of 7, for 8, and for 9. We can't agree on what good diabetes control is. And in fairness, medicine is complicated, and what may be good diabetes control for a 70-year-old is not good diabetes control for a 45-year-old. But it just makes the point that even on something as simple as agreeing on what good diabetes control is, we have 3 different quality measures.
Yeah, that's a really great example. But it does also remind me of something that Stace Mandel, the acting director for our office, mentioned at the very start of this conference, that not all burden is unnecessary burden. So some burden isn't actually burden. It's just part of doing the work. And so it's certainly, when it comes to things like quality measurement, you can really see how that plays out, because quality is the number one thing in healthcare, right? And making sure that we're tracking that quality and working to improve it is certainly part of healthcare. But to the extent we can make it less burdensome, that is our goal. So I do want to ask a follow-up question. When we talk about moving to digital quality measurement, can you explain a little bit about what that means? And just to tie it back to the standards we were talking about earlier, do we envision that the CMS quality measures will move to the HL7 standard, which our team likes to focus on, which is Fast Healthcare Interoperability Resources, or FHIR standard?
Yeah, and we are moving in that direction. And obviously, it's a large, complicated healthcare world out there. And I would say that life is a bell curve, and getting everybody to move in that direction is a challenge. And I think a lot of health systems aren't going to invest the money until they're told they have to. So part of that is sort of that push-pull kind of thing of, when you're saying you have to do this, are you really pushing too hard, or are folks never going to do it unless you actually force them to do it? Right now, we have about 55 FHIR-based quality measures that are ready to go. We don't have a system ready, capable to accept them, but those systems, those FHIR-based ECQMs are there and ready to go once we do. And yes, I mean, there is a long-term goal of getting us to digital measures, and digital can be defined different ways. And sometimes people define digital as just there's no clinician burden associated with documentation. And sometimes a stricter standard is it has to be FHIR-based to have full interoperability. And I guess in my sort of simplistic way of looking at life, if the clinician can do their job, take care of their patients, and not have to do additional documentation, then that's digital, regardless of whether it's FHIR-based or not. And then, I think that's basically what I might add on that topic.
Okay. Thank you. That's very helpful. And good to know that, again, that we are looking at all of these things. I think it's important to point out that, we have a lot of government programs for a lot of different things. It's good to know that they're working together and with industry to try to find ways to streamline each of these processes and find ways to reduce burden. So lots of great work happening over in CCSQ and in Quinnipiac, your area. So moving over to Dr. Graham. So standards, prior authorization, quality measures, oh my, these are only a small part of what you have to consider on a day-to-day basis in the operations of a health system. How do you manage all of this with your providers while also balancing the care of patients?
Well, thank you for the opportunity to participate. And it is a challenge, and we approach it, I think, like many of the participants that are in the audience are going to. We put the patients first. We have to always put the patient first and foremost of what we do. Increasingly, we have to recognize we have to put our clinicians second on that list. We have to make sure that we're giving them the tools and the support to be able to take good care of their patients. So as Dr. Klein just mentioned, if they're doing the work that is necessary to take good care of their patients and do the appropriate documentation, we should be able to let the systems work smartly and work intelligently to provide the submissions that they need to from that. It shouldn't require them to do extra steps. we actually approach it very much for not just our providers, but all of our clinicians. We see our nursing burnout probably equal to or even greater than our physician burnout at this point, because of the different standards they're working on. Many health systems have solved it the way we have over years. We've built out a lot of personnel heavy, assistive, back end tools, back end people to do the work. So we're trying to take it off those front end clinicians. But increasingly, we're seeing that those people are leaving the clinical workforce to do the back end work. So it furthers our workforce challenges. So it becomes kind of a vicious circle for us. With that, we're seeking to do much more automation of the tools so that we can eliminate those back-end personnel roles and make them more automated. That's what we're really trying to do to address what we need as a minimum standard for documentation for our providers. I'll use a quick example. When we sought to examine what we were doing with our nursing documentation in some of our hospitals, we found that we thought we had designed it perfectly. We thought it was the best system, the minimal that they needed to document. After a 6-month project, we found that we could give back 52 minutes to every 12-hour shift nurse in the hospital, a sustained improvement that we kept for 6 and 12 months, just by looking at what we really need to document and what can pull from other systems. I will approach just briefly also the whole idea of the interoperability. We think of it most often between EHRs or within the EHR, but a lot of the data that we need for some of these submissions and some of this work comes from another system, another source system, those secondary ones that were mentioned earlier. So we need all those to be talking together also, so that we can produce output that has as least clinician intervention as necessary.
That's yeah, I mean, that's a lot to monitor and track, and I think you've got your priorities straight, certainly with the patients and then the providers, but but there are still challenges, and so I am curious, in what ways can technology better serve your organization? And when you introduce changes to technology, how does that I guess equally improve the process, but does it also include challenges for your providers? So I'm thinking of whenever you implement a new feature in Outlook, I know that it trips me up for a couple of days and feels a little bit burdensome for me to have to work through just getting my own email. But in a health system, when you have to roll out these changes to all of these providers, what do you see as the challenges with that process, but also how can the technology serve you better? So sort of
I think it's a multifactorial approach, Alex. It's a great question. I don't think we're any different at LifeBridge than most of the organizations out there, that some of the pain of the burden of documentation is self-inflicted. It's, as I just mentioned, it's how we've designed our system. It's how we've implemented them, how we've not gone back to optimize them and make sure that they're changing to a changing regulatory and reporting requirements. And I think that's a challenge for every organization to keep up with. I think increasingly we're finding ways to partner with vendors, whether it's electronic health record vendors or others that support our systems and support our clinicians, to make sure they're being designed from that clinical perspective. I think I'm glad to see in this point of my career that we've moved past a lot of the design based on the database and based on simple reporting requirements or billing requirements. We're moving to a truly clinically oriented record that allows us to input the data necessary, utilize data that's already rich within the database, and make it available to the clinicians and make it available to them to do their job more efficiently. The comments were made about not just the government reporting, but value-based care plans and other reporting. The system should be smart enough to know that about the patient and be able to pull and adapt and modify the measure a little bit in its reporting capabilities, because it knows what the patient is on. That's again that interoperability of our systems in the back end for us that's outside the electronic health record. So we're trying to minimize the self-inflicted impact that we're having, but also bringing to bear new technologies, some of which we can talk about a little bit later, but new technologies that allow us to pull the richness of data that exists, summarize it, synthesize it, and put it to the right place as easily as possible. And again, we're looking for our partners in our vendor community to work with us on that, for providers, for advanced practice professionals, for nurses, really for the whole clinical care team, because that's when the data starts to become useful for everyone.
Yes, that's a critical point, and that's of course what we're all trying to get to. I'm going to come back to Dr. Nguyen here. In this conversation so far, we've talked about the payer perspective, we've talked about the quality management perspective, and a health system perspective, and all of it does come back to this idea of standards and technology to support data exchange, which ultimately, we hope leads to burden reduction. Can you talk to us a little bit about the opportunities within the standards community for folks to get involved, to learn more about this, and some of what some of the accelerators do, so that folks can understand kind of where they might be able to have the most impact if they want to be involved in that?
Yes, I'd love to. So we encourage folks, and I'll put it in the chat and it will be shared with the audience. We often will direct folks to a number of our websites. One is the hl7.org, which is the generic website. Another is confluence.hl7.org, which is where we really document our work, the connect-a-thons, the work groups, the working group meetings. You'll get a lot of information there. It's also, we have sites for the fire accelerators. So just to name a few, Da Vinci, we like to say the accelerators divide up the work, they don't divide up the community. So the work of Da Vinci is really looking at payer-provider interchange, and we have a large number of payers, providers, and vendors. We have the Karen Alliance, which is also similar, but they're focused on the consumer to the business relationship. So they have the Karen Guide to the Blue Button, and they're working on digital identity cards. We have Gravity that's working on social determinants. Helio is working in public health. Vulcan working in pharma and clinical research. The Argonaut Group, which was an accelerator before we had the term accelerator, really develops those new technologies based on fire, the bulk data in order to exchange large volumes of data asynchronously, or the SMART capability that allows us to create applications that we can use in the same application in multiple platforms. So they do a lot of that work. And Codex is working on a lot of terminology. They've started and been successful with oncology. They've engaged the cardiology community and the genomics community. And I'm pretty sure I have forgotten somebody, and I will be told, FAST. So the Fire at Scale Task Force was initially convened by ONC, and then this past year, HL7 is now the convener. And they were looking at how do you take these components of fire, which is traditionally just entity to entity because it's an API, but we'll need things that how do you find the endpoints and trust the endpoints, and how do you make sure we do a consistent approach to patient identification, patient matching, those kinds of things. So they're looking at the scale. So if you think of them as infrastructure, the guides that Da Vinci and others develop kind of ride along that infrastructure. So I'll put some links to these sites in the chat, and we'll share them with the audience. But we encourage folks, participation in HL7 is free. If you want to vote on a ballot, you can. There's a small charge if you're not a member, but we encourage the community, especially for those of you who actually don't think of yourselves as standards developers, but you're subject matter experts. And we really need your input, especially we're working on the patient cost transparency. It's really challenging because there are lots of approaches that the clinical community uses to identify participants in a particular service. So we need your subject matter expertise, even if you don't think you're a standards developer.
I think that's a good point. I will point out that CMS participates in many of the fire accelerator work groups, and we learn a lot from just participating in those groups and hearing the discussion. We don't always vote. We try to just absorb the information. But I will say that it's an excellent way to just find out all of the efforts that are going on in terms of interoperability and standardization within the HL7 community. So there's a lot to learn there. You can also just about earn a master's in informatics if you browse the HL7 website long enough. There's tons of information there, and you could go honestly for weeks. So it's good to know that those resources are available. Thanks for sharing those links. So I want to ask a couple of discussion questions here. So feel free to go between everyone, but I'm just going to start out with an opening question. Which is, I want us each to talk about a piece of technology or a trend that you're watching that you're particularly excited about, that you think might have an impact on burden reduction or on reducing administrative burden in healthcare. And I am going to selfishly start since I have the mic at the moment. And I want to start because I want to take this opportunity to address a common source of burden that I've been hearing about throughout the discussions today, and even in the chat, which is provider directory burden, or what we refer to now at CMS as healthcare directory challenges and burden. We all know that there can be challenges with healthcare directories. They're often inaccurate despite payers' best wishes. We know that it can just be challenging to keep all of those providers' information up to date. This is something that we've been talking about for years in healthcare. So it's not a new problem, but we're looking at the solution in a new way. So last October, CMS released an RFI, request for information, in the Federal Register regarding what it would take for CMS to establish a national healthcare directory that would be sort of like, in simplest terms, like a one-stop shop for directory data, and one place for folks to come and a centralized hub for providers to come and update their information, and then to be able to share that with health plans that are out in industry. So if you are interested in reading more about that, you can look at the RFI that was, I think it was published like October 6th, October 13th. Anyway, it's in the Federal Register, or you can certainly reach out to our team, the Health Informatics and Interoperability Group at CMS. But this is, I think, an opportunity. It's not one piece of technology, but it is one technological approach that can certainly could potentially reduce burden in a significant way by streamlining all of that directory data into one place. The other thing that we talk about in that directory is the potential for the use of, or for including digital endpoints. So, and that would be, we talk about that, digital endpoints for not just the provider side, but also the payer side and all other entities in healthcare. And that is so that we can electronically connect, that EHRs can directly connect to the payers without having to hard code those digital endpoints, but instead they'd be made available through the national directory for everyone to use. So really interesting, well, I believe really interesting use case. And I hope that all of you do as well. I noticed that someone had mentioned that in the chat and it was getting a lot of votes. So just something to consider. But now turning to the rest of the panelists, and I'll go in the order that we started. So Dr. Nguyen, if I can go back to you again, can you tell us about a piece of technology or trend that you're watching?
Yeah, follow on really quick on your comment about directory. We have a DaVinci PlanNet IG that was in the Patient Access API rule, and FAST has developed a national directory. And I think the challenge is, do you go from just a phone book like a DNS server, or do you want like a Google Maps where they tell you a whole bunch of things? And that's part of the challenge. But I'm like most thinking about, where does AI fit into healthcare? We kicked off a discussion at the recent working group meeting in plenary. We had speakers from Microsoft and others and panels to think about, what is the role of standards in AI? Are there common ways that you would represent the prompt or the question? Do they have an opportunity to maybe support activities like having, instead of a scribe, the ChatGPT kind of technology summarize a discussion reasonably well? I say they're a good intern without much wisdom, but they do enough that you could formulate a summary. And then there are all those other things around clinical decision support and prior auth, things that you could do potentially with AI. But what we're focusing on is first establishing a level set. What is HL7's community understanding of the AI life cycle? And then figuring out the use cases, because we can always jump to the use cases and they can be the kind of the bottom up approach. But I like the top down approach as well, to make sure that we are all in a common understanding of what these different AI, large learning models and such, what role they might have in healthcare, safety, privacy, all those other aspects. So that's what we're looking at.
That is very interesting. And I'm not going to presuppose any of Heidi's answers, but I will say one of the questions that we often get is, what is the role of AI in prior authorization decisions? I'm not sure we want to go down that path, but I just want to mention, since that's your answer and I'm transitioning to Heidi, it just seemed like an interesting place to mention that. So Heidi, what is your piece of technology they're watching?
Yeah, and that was something I was going to mention as well. But what I'd like to start with, honestly, is, for me, incredibly excited for the CMS interoperability PA rule to go to final. That's first and foremost in my mind, because as I'm talking to provider organizations in our footprint for Regence Health Plan, providers are busy, right? They've got a lot going on, and it's been hard getting that technical integration that has to happen. We have an app available within the EMR that they have to technically integrate to. And that, for me, is a little bit of a roadblock, which takes me to potentially, right, the QHIN model under TEFCA, being able to maybe just access a QHIN and they can all speak to each other. I think that gives us a direction in greater expansion that kind of eliminates a few of the roadblocks that I'm experiencing in trying to get providers to connect to this workflow. And then lastly, yes, large language models are absolutely at the forefront of a lot of what we're doing. I've done several proof of concepts with a team. I have a data science team that I utilize internally with our organization. And I think for me, it's how do you use them to hit, I call it the sweet spot internally, right? You can identify a lot of things using these models, but you've got to identify the right things and not create too much noise to really be impactful. And so that's something we are consistently working on within the prior auth space. So when you get a prior auth in, I can pull the discrete data elements out of the EMR, right? I can pull a diagnosis, I can pull a vital. That is easy to get to, and it typically exists. But there's a lot of information in progress notes like genetic testing. I have to look at family history, right, to ensure there's risk there potentially on a request. So how do we get to that information as fast as possible using large language models? And my vision, honestly, is when we hit that sweet spot is then to auto approve and not have a human look at it.
I'm sure there are a lot of providers out there that would be excited to hear about that. But also considering we need to take our measured approach to all of this to make sure that we're getting it done right. So since you mentioned TEFCA, I want to just call out, because our friends at the Office of the National Coordinator would be so disappointed if we didn't say something about TEFCA here, that the Trusted Exchange Framework and Common Agreement, or TEFCA, is recently becoming more of a reality, in that ONC has named the QHINs that will support TEFCA and support data exchange under TEFCA. And so one of the interesting use cases is looking at whether TEFCA would be able to support things like electronic prior authorization and making some of the connections between the payers and providers, or whether it could support connections between payers and providers just for sharing of patient data. So super interesting to follow that as well. And we look forward to hearing more about that from ONC over the coming weeks and months. Dr. Klein, I'm going to go to you. What's your piece of technology that you're watching?
Yeah, I'm going to circle back to where I started. I'm going to smush together two concepts, which are digital quality measurement and interoperability. As I said at the beginning, my version of heaven is when I can see my patients and not have to document every quality measure. And I think having digital quality measures and interoperability gets us to that world where, again, we take care of our patients. We let the IT measure quality and interoperability, the ability to have standardized data collection and export to data analysis, to analytic systems, gets us there. And so that's two things: that's digital quality measurement and that's interoperability. I will say one other thing. Actually, a couple of things that probably hasn't been said here but needs to be said, which is along all criticism of quality measurement, I understand that. You can't improve what you can't measure. So there have been, I think the title of a previous talk was improvement, not measurement. And you don't get to improvement without measurement. So we want to make measurement as small as possible burden that there is, but I think it's a fallacy to think we can improve something if we're not measuring it. The other thing I wanted to talk about was sometimes there's this tendency in our world that as things get easier, rather than saying, oh, things got easier, we gave somebody 5 more minutes in their day, we just add more things on top of it. And we have to be careful that we remain parsimonious in that. And that just as we have automated data collection and natural language processing and all those things, we don't say, oh, great, the clinician has 10 more minutes in his day, let me add these other things. And I will give you just 2 really quick examples. I was once part of helping develop an oncology EMR. And the IT person said, what information we really need is the size of the chemotherapy vial that the nurse used to give that dose of chemotherapy. Now, I will tell you that the IT person did get out of the room with his life, barely, but that was not added. I will give you 2 other examples that I deal with on a daily basis in the pediatric ER, and the clinicians among you will smile. Every time I write an order for Motrin, which, as you can imagine, I do often in a pediatric emergency room, the EMR asks me if I've checked a creatinine, because many people know if you use long-term ibuprofen use, you're going to damage the kidneys. But this is my 1 dose of ibuprofen for this kid coming to the ER. I don't need to be able to click, okay, I didn't check a creatinine. I also prescribe in this pediatric ER enemas quite often, as you can imagine, for constipation. That's something I also do a lot of. And every time I write an order for an enema, for a Fleets enema, I get warned that I haven't checked the magnesium and the phosphate on the child. So again, I don't know who put those warnings there, but I think it behooves us, as life gets easier for clinicians because things are automated, we don't use that opportunity to add more on top of things, but we actually ask ourselves the question, is this a clinically relevant question, a clinically relevant warning?
Really, really, really good points and helpful examples. So thank you for that. Dr. Graham?
Well, thank you. I would have been shocked if we got to me as the last one and AI hadn't been the central theme. Because really it is. And we're taking the approach of a safe and effective approach as a health system. First, putting some guardrails around what and how we should be using AI technologies. But we're looking at them from so many different perspectives, from documentation assistance, where they can give you an easier way to get your dictation summarized, as Dr. Wen said, that sometimes it has the wisdom of an intern and it needs some massaging. And so where are the areas that we can allow it to do more for us, and summarizing information about a patient that can pull out some of those details that we need to know, that can bring it forward to us so that we spend less time in chart review. How can AI tools help us with the major burden of our inbox or our message center, where we've got so many of the things that come into the inbox don't need me. So we should have the technology redistribute that 70% that somebody else needs to take care of or look at. But it's also about nudging us. It's using the intelligence that can be in there as I'm doing my documentation on a patient. If it can nudge me slightly to add this one other little detail that would then get me to this quality that can automatically be submitted then and be automated. So that's the kind of intelligence we're looking for, to help us guide the pathway, to make it easier on our dictation, documentation, but also to guide us in ways that get us to that maximal documentation the first time, so that we don't have to go back and do multiple other steps. And again, this is broadly for all of our clinicians, our providers primarily, but our nurses also are going to be taking advantage of many of these proofs of concepts that we're entering into right now.
Yeah, I think we all have certainly something that we're watching, and improvements that we can continue to see. My next question actually was going to be, where does burden, do you see that burden continues to exist that you don't see a technology solution for? But I think I'm afraid that if we go back around, everybody might say AI. So I think what I'll do instead is just say, what do you have any closing thoughts that you would like to share with the audience? And if you do have a source of administrative burden that you see an opportunity for technology to support in, what would that be, and how can we help?
I'll start. I would say, if you haven't started your FHIR journey and have a group that understands it from developers all the way to executives, you should start now. I said this 5 or 6 years ago, and some companies who are really advanced took that advice, because even as an executive, if you're developing strategy around interoperability, you have to understand a little bit of FHIR. I can teach an executive in about an hour. If you're a manager, if you're a buyer and you need to vet companies that are saying that they do FHIR, how do you do that? And as a business owner, you have to be able to read an implementation guide, work with a developer to help them understand that there are things that you want to implement that makes no sense clinically or in a workflow, even if FHIR does support it. So start your FHIR journey now if you haven't. If you're already on the journey, keep advancing your expertise and your understanding, because it's not one guide. One guide actually combines knowledge from other guides to be able to make this more sophisticated workflow guides, like the burden reduction ones, feasible. So start your journey and come to HL7 and we'll help you on your journey, or others, our consultants and members will help you. So thank you.
I will say that CMS offers FHIR training to our executives as well. And we have, for the last couple of years, offered classes that range from multi-days to 1 hour sessions to help. And Viet has been very kind to help with that in our journey. So we're spreading that word around CMS as well. Does anyone else have anything they want to share as closing thoughts or opportunities for additional burden reduction?
I'll jump in and say amen to Dr. Wen's thing about start your FHIR journey, because at some point in time, the expectation is going to be that you can export FHIR-based data using an API exchange. I think the second thing I would add is start working on making sure your data is clean, which is sort of part of the export of large data. So if you export your data, just a bunch of junk, that old expression, garbage in, garbage out, then that's not going to work, and it's going to circle back to you, and you're going to have a lot of manual cleanup to do. So along with the FHIR journey, start your data cleanup journey.
I guess I would just add, taking that perspective that I mentioned before from the provider perspective of put your patients first and put the provider second, and always ask those why questions of why are we needing to document this? What clinical benefit is this going to have for my patient downstream, which then gives me the assurance that I'm doing a better job clinically and taking care of them. If we always are asking those questions, then we're not going to have a lot of extraneous, unuseful, non-value added material being put in front of them to document and or to try to remember. So I think that's a key for us, is always putting that patient first and provider second.
And I think lastly for me, just representing a health plan in this conversation and the work that I've done, is we have to break down the silos. If we continue to just sit in our silos and keep moving forward, we're going to continue to use proprietary vendor workflows, and we're not going to advance and automate and reduce burden. And so that's my number one message, is let's put some things aside, let's start working together and serve that foundation. And for us, right, my whole message is we started with prior authorization. That was first and foremost for us. But what it's really done with the providers that we've worked with is broken down that silo. And I meet with some of our providers weekly, and they're talking about now future use cases. This is great. This is amazing. My staff is seeing an improvement. What else can we do with this workflow? And now that we have this integration and we have a payer at the table willing to listen to us. So I actually have a prioritized laundry list of different things we're going to do, not just relevant to prior authorization, but the other use cases that we're talking about today.
That is incredibly cool. Thank you all so much for this fantastic conversation today. I hope everyone listening finds this as exciting as I do. I think there's just so much opportunity in this space. The technology exists, it's out there. We just have to find the right ways to use it. And as you've seen, it can streamline a lot of processes, save clinicians and patients a lot of time. And there's just so much opportunity. So thank you again for joining, to all the panelists. And to all of our attendees, please visit the attendee hub and open the discussion board labeled "Tell us your thoughts," and let us know what development in healthcare you're most optimistic will have a positive effect in 2024. We're interested to hear your feedback.